University. He is going to give a talk in current treatment options for subchondral bone injury. Please welcome.
Good morning, Chairman, Co-Chairman, and all the audience. My name is Dr. Chaiwat Chuaychoosakoon from Prince of Songkla University in Thailand. First of all, I would like to thank TOSSM-JSOA for giving me the opportunity to present this topic. Today, I will talk about subchondral bone injury. It's all about treatment options. What is the subchondral bone? Subchondral bone is the bony layer beneath the hyaline cartilage and the cement line. The subchondral bone can be divided into two parts anatomically. The first one is a compact polyporous calcified plate crisscrossed by multiple vessels and nerve fiber. And the second one is a cancellous bony structure adjacent to the subchondral bone plate that undergo continuous bone remodeling. For the functions, the subchondral bone plate is the function for the cartilage. The first one is the mechanical support, and the second one is the nutritional support. If this one has an injury, it will affect the cartilage metabolism. How about the injury? If the injury, the patient will have the clinical symptom of pain, dysfunction, and progressive cartilage damage. For the classification for the subchondral bone injury, classification based on etiology, based on underlying mechanism. Based on etiology, for the cause, it can caused by overuse, direct trauma, or malalignment. We found that there are two types of MRI on the subchondral bone injury. It depends on the surface of the condyle surface. The first one, the condyle surface is intact, and the second one, the condyle surface is not intact. I mean that is osteochondral injury. As we know, the most common injury is the osteochondral injury. Today, I will focus on talking about osteochondral injury. For the incident, arthroscopic finding found the incidence of subchondral bone injury or osteochondral injury is approximately 60%. And the most common area is the medial femoral condyle. For the injury, we found that more than 50%, the size more than 2 square centimeters. For the treatment, we have some factors that the surgeon should be determine and evaluate. The first one is the age of the patient, and the second one, the activity of the level. And the lesion of the injury also the main factor that the surgeon should be concerned about the location and size, about the concomitant injuries and the alignment. Subchondral bone injury or osteochondral injury can divided into two injury. The first one is the head concomitant injuries, and the second one only osteochondral injury. For the concomitant injury, I will, for example, is a varus malalignment. As we know, when we met the patient with the varus malalignment, the option is the correct alignment, is the high tibial osteotomy, is the gold standard. There are many options to detect or determine the degree of alignment correction. The first one is the cable technique, or the navigator system, or the patient-specific cutting guide, and the K-wire. Today, I will propose the technique of the K-wire to measure the degree of alignment correction. Our team proposed this technique in arthroscopy technique and OJSM. We invent the device. This device can measure the degree of the K-wires, and we have been granted the patent, and nowadays we're waiting for the patent. Today I will show you how to use this device. Firstly, after you continue the step out of osteotomy, after you cut the bone, you should insert 2 K-wires. And the first step, you use this device to measure the degree or the angle of these 2 K-wires. After that, you can open the gap, and again, you measure these 2 K-wires again. The changes of angle of these 2 K-wires is the degree of alignment of correction. And again, you can use this technique to determine the posterior tibial slope. I mean that you should insert these 2 K-wires parallel before opening the gap. And after opening the gap, if these 2 K-wires remain parallel, it means that the posterior slope is still same before opening the gap. This slide shows the high tibial osteotomy. So next move to the isolated osteochondral region. The osteochondral region, the surgeon should measure the size and the depth. This algorithm shows the treatment option for the osteochondral region. First, I will start with the marrow stimulation. The marrow stimulation is the penetrating of the subchondral bone plate, and then it creates a conduit between the bone marrow and the injury cartilage surface, allowing cellular elements access to the defect. This slide shows the healing cartilage. You can find that the cartilage is not the hyaline cartilage. This technique is low cost and low morbidity. We found that some literature show that when do this technique in the grade 2 to grade 4, the patient can return to pre-injury level for timing is about 9 months. But there are failure rate in this technique too. For the 5-year failure rate is about 17 to 21%, and for 10 years failure rate was about 6 to 32%. When comparing this technique to OAT, we found that marrow stimulation has a higher failure rate when compared to the OAT at 2 years of follow-up. There are some points of concern of this technique. The first one is the healing cartilage is the fibrocartilage, is the weaker. And the second one, when you do the microfracture and it fails, when you do the second operation with ACI, we found that there is a higher failure rate of ACI when comparing to the primary ACI. There are some techniques to improve the outcome of the microfracture. We found that when we use the small and deeper device to create the marrow stimulation, the result will be better. You can modify to use the K-wire to penetrate or to do the marrow stimulation. This table is the summary of clinical decision making for marrow stimulation. Now, let's move to OAT. OAT is the concept, it is transferring hyaline cartilage. We taking from the lesser weight-bearing area, similar curvature, similar thickness, and move to weight-bearing area or move to the region. The candidate of OAT is a young, healthy, and active patient, and the region should be less than 3 square centimeters. For the literature review, we found that the outcome, 5-year outcome of the OAT is quite good. Patient satisfaction is about 81%. Complication rate was 13%. We found that OAT is good in the area of femoral condyle, but it's slight controversy or is less studied in the area of Turkey or Pattaya. When comparing OAT to the marrow stimulation, we found that OAT can return to sport activity faster than marrow stimulation, lower reoperative rate at 5 and 10 year follow-up, and better functional outcome by Lindstrom score at 15 years. But OAT is limitation for about the size. If we found the patient had a lesion more than 3 centimeters square, we can use autologous scalp transfer. This is shown in the summary of the autologous transfer. The candidate for this technique is young, active patients, and the defect more than 2 centimeters square. You can transfer at the patellar area or femoral condyle area. There are some limitations of this technique. The first one is the graft cost. The second one is a long period of non-weight-bearing area, non-weight-bearing postoperatively for the donor and the host bone integration. And the last one is the disease transmission. For the outcome, we found that 12 years outcome, 40% can return to sport activity. We have the failure rate about 25%. There are some factors for the failure. The first one is the bipolar condyle defect region. The second one is the older age. The third one is the high BMI, and the fourth one is the male. For the ACI, we know that the healing of the cartilage for the ACI is quite good. It's maybe the hyaline cartilage, but this one had the 2-stage procedure. The first one, the surgeon should biopsy from the lesser weight-bearing articular surface and then the culture, and then the surgeon should implant back into the knee during the second stage. For the biopsy area, the surgeon should the area of biopsy from the lesser weight-bearing area and then culture, and then implant back to the defect area. How about the outcome? We found that at 2-year follow-up, 85% the patient can return to activity and 66% the patient can return to sport. And outcome for 11 years, we found that only 10% of the failure rate. There are some complications. The first one, polyosteal patch hypertrophy. The second one, high reoperative rate for the debridement, bulky suture, and cell leakage. This slide shows the outcome of the ACI. Nowadays, we have the third generation ACI. This one is an autologous chondrocyte. The outcome of this technique for 10 years can improvement in the patient satisfaction and improvement in the functional outcome. And also we can use particular juvenile allograft cartilage. It is a single procedure. We use the allograft live cell from juvenile donor and held in the place with the fibrin glue. For the outcome, it can improvement in pain and functional outcome, but it has a high failure rate and it needs to revision about 50%. For the outcome at 2 years for the patellar defect, reported by Dr. Durkin, his team found that 78% of patients can feel the defect and 67% having a normal or near normal cartilage on the MRI evaluation. And the last one, we can emergent technology such as the stem cell injection-based therapy or scaffold derived from biomaterial. For the MSC, the surgeon can harvest from bone marrow from the donor tissue, autologous adipose tissue, an option to inject to the joint or embed within the collagen scaffold. This is the lat model, the lat study, and Professor Satu found that the healing of this technique is quite good. And the last one, the surgeon can combine technique by injection with the procedure, such as you can combine PRP, MSC, or with the microfracture. We found that this technique can improve pain and functional outcome. This is like the summary of the technique to deal with the osteochondral region. That concludes my presentation. Thank you very much.